And it is our pleasure to introduce today our speakers, Dr. Yilun Koethe. Dr. Koethe graduated summa cum laude, the highest honor, from Tufts University. She obtained her medical degree from Duke University. Following medical school, she completed an internship in Santa Clara Valley Medical Center, and she did her residency in diagnostic radiology at University of California in San Francisco. Following residency, she further specialized in vascular and interventional radiology at the Miami Cardiac and Vascular Institute, which is a world-renowned center for diagnostic management and treatment of vascular diseases. Currently, she is the assistant director, a professor of OHSU, Oregon Health and Science University, which she also trains other physicians in interventional radiology as well as in interventional radiology techniques. She's also the director of the interventional oncology, also at OHSU. Dr. Koethe efforts is to, besides her expertise in minimally invasive cancer care, and for a full spectrum of disease, her expertise and efforts is to also develop other therapies as well for hepatocellular carcinoma and liver metastases secondary to colorectal cancer, as well as neuroendocrine tumor. Dr. Koethe firmly believes in providing individualized, highest quality care for each patient and each of her patients. And as also one of her interests is also include women's health, men's health, arthritic pain management, as well as minimal invasive cancer surgeries. As you can see, Dr. Koethe is a wealth of knowledge and also a phenomenal physician and a friend in the neuroendocrine tumor field. And without further ado, Dr. Koethe, the floor is yours. Thank you.
Thank you for such a wonderful introduction. I'm honored to be here today to share with you a little bit about how interventional radiologists and interventional oncologists can provide minimally invasive treatments for neuroendocrine liver metastases. And these are my disclosures. So today, I want to introduce everyone to the field of interventional oncology and discuss some of the therapies that we offer patients with neuroendocrine tumors. And we will also dive a little deeper into the three main types of treatments we can offer patients with neuroendocrine liver metastases. And these are ablation, chemoembolization or embolization, and radioembolization. So interventional oncology in the recent decade really has become the fourth essential pillar of a multidisciplinary oncologic care alongside with medical, surgical, and radiation oncology. And we are physicians who offer minimally invasive procedural treatments under image guidance. So some of the procedures we do include biopsy of the tumor under CT or ultrasound to get a diagnosis, or placing a chest port to allow chemotherapy infusion. But a major role we play in oncology is providing a few major treatments that actually kills and controls neuroendocrine tumors in the liver. So neuroendocrine tumors often present with liver metastases. In fact, approximately 50% of patients with pancreatic NET and 75% of small bowel NET patients will present with liver mets or will subsequently develop liver mets. And patients often present with significant tumor burden because the disease is often indolent. Unfortunately, less than a quarter of these patients will have cancer that will allow complete resection. However, studies do show that if we are able to debulk and reduce the burden of disease in the liver by 70%, we can improve overall survival and progression-free survival in patients with carcinoid, pancreatic, and small bowel neuroendocrine tumor. In addition, cytoreduction can also improve the hormonal symptoms related to cancer. Surgery is typically the first-line therapy for cytoreduction, However, many patients aren't great candidates for surgery. So today I will focus on the three major cytoreductive treatment options for the metastasis in the liver for patients who are typically not good surgical candidates. So the first one is ablation. So ablation is a category of treatment techniques that cause tumor destructions by either burning the tumor, causing coagulative necrosis, freezing the tumor, or using electricity to cause apoptosis of the cells. And ablation can be done laparoscopically or percutaneously like we do in interventional radiology. And the goal of treatment is to treat the tumors individually. Typically, up to 5 tumors can be treated safely in a single session, and the goal of ablation is for cytoreduction or symptom control by killing the tumor while preserving as much of normal liver as possible. In certain scenarios, it can be curative, and it is best reserved for patients with a limited number of tumors and whose tumors are less than 5 centimeters in size. It is typically done by making a tiny incision on the skin overlying where we want to place the needles. And through the tiny incisions, we place 1, 2, or 3 probes into the liver tumor under imaging, usually under CAT scan or ultrasound, to make sure we can achieve the treatment zone we want. Here, for example, you see an MRI showing a tumor in the right lobe of the liver. And the arrow shows the 2 microwave probes I place into the tumor. And during the procedure, we can see the treatment zone to make sure I can kill the entirety of the tumor. And this type of treatment really minimizes the amount of collateral damage to the normal liver. It can be done between 1 to 3 hours and can be done either with moderate sedation or general anesthesia. The recovery is very quick, and most patients don't feel any pain or symptoms after the procedure. In terms of efficacy, it is often reported in conjunction with surgical resection. A meta-analysis have shown that in select patients, radiofrequency ablation can lead to partial or complete symptomatic relief in 90% of the patients, with a mean duration of symptomatic relief of 14 to 27 months. However, there is a relatively high rate of local recurrence with radiofrequency ablation of 10 to 25%. In addition, as expected with metastatic disease, additional liver mets growing elsewhere in the liver is common. Microwave is like radiofrequency ablation in that it uses heat to burn the tumor, but it creates a larger ablation zone and overcomes some of the limitations of radiofrequency ablation, such as heat sink effect. It has essentially replaced RFA in most centers because it is more effective. Cryoablation is a method that freezes tumor. However, it is typically not used in the liver because of the high bleeding risk. And irreversible electroporation is a technique that uses electricity to cause apoptosis in the tumor cells, and that is typically reserved for treating tumors elsewhere where microwave or RFA cannot be safely used. And the next treatment I want to talk about is transarterial embolization. So embolization is the delivery of embolic, which can be particles, lipoidal, or beads, into arteries in the liver, supplying the tumor with the purpose of occluding the blood vessel. And transarterial embolization, or TAE, is also known as blend embolization. This procedure only uses particles without chemotherapy, whereas TACE, with a C in there, stands for transarterial chemoembolization, and delivers chemotherapy to the tumors in addition to something that occludes the blood vessels. And there are 2 main types of chemoembolization. Initially, we have used particles with drugs attached to it and called drug-eluting beads. However, that is no longer used in neuroendocrine tumors because multiple studies have shown that there's a high 10% complication rate when it is being used. What we refer to TACE now is a mix of water-soluble chemo with lipoidal, which is poppy seed oil, to create a motion which is then used to embolize tumor. In the picture below, this is what the mixture typically looks like. And the rationale behind TACE and blend embolization is that while tumors derive its blood supply from hepatic arteries, normal liver parenchyma derives most of its blood supply from the portal veins. Therefore, treatment in the hepatic arteries can more selectively treat the tumor over the background normal liver. And neuroendocrine liver metastases are also great candidates for these embolization because they're often hypervascular, which means they're supplied by the hepatic arteries. And even if hypervascularity is subtle on the CT, it is often very hypervascular on angiogram, as shown here. So how is it done? Well, in the most simplified way that I explain to my patients is that we make a pinhole access through the radial or the femoral artery. And we use really thin catheters to select hepatic arteries supplying the tumors. The treatment is most often lobar, as in half the liver at a time. This is because patients who get TACE or transarterial embolization tend to have a lot of disease. The procedure is done under live X-rays, and we can see the tumors by the way it takes up contrast in the blood. And the contrast in this picture is dark in the middle image. You can see all these round tumors taking up the contrast. And on the right, you can see beads of chemotherapy oils that are being delivered to these vessels during the procedure. There isn't any consensus on the type or size of the particle used, and depends a little bit on local availability. Typically, 100 to 500 micron beads are used. There is also no consensus on the type of chemo agent to use for TACE, given there's not a lot of prospective data in that. Doxorubicin is most commonly used for historical reasons because it is drugs used for hepatocellular carcinoma. And more recently, oxaliplatin has been used for patients with carcinoid heart disease because doxorubicin has cardiotoxicity if that is given systemically. So the NCCN guideline recommends blend or chemoembolization for well-differentiated neuroendocrine tumors that is liver dominant and unresectable if the patient is symptomatic despite being on somatostatin analog or other treatment, or progressive despite being on these treatments, or have a significant bulky liver disease and cannot undergo surgery. Studies have shown that both TACE and blend embolization have about a 85% symptom control rate and approximately 60% objective response rate, and allows for median overall survival of 3 to 5 years. It does have side effects and complications like every procedure do. It is most commonly associated with post-embolization syndrome, which presents as nausea, vomiting, and abdominal pain. And this is seen in up to 40 to 70% of patients. But it's short-lived and lasts less than a week and is managed conservatively with pain medication. It is also associated with intraoperative carcinoid crisis in approximately 20% of the cases. However, the overall risk of permanent liver damage is very low, which makes this procedure overall very safe. One of the benefits of TACE and blend embolization is that they can be used repetitively. So how well does it work? Well, a recent single-center retrospective study recently addressed this question by looking at 555 patients in TACE in 202 patients over a span of 15 years. And they followed these patients after the procedure. They defined each cycle of treatment as 1 to several sessions needed to treat the entire liver. And they found that with more cycles of TACE, liver progression tends to occur a little faster, which is expected. And the overall median time to tumor progression is 26.2 months, which is still high and supports TACE for global control. In addition, they saw that the response rate is sustained over multiple cycles of treatment. By mRECIST imaging criteria, the objective response rate was 68% at cycle 1, but drops no lower than 57% at cycle 3. And here, both mRECIST and RECIST were shown to be associated with overall survival. And those who responded lived 7 to 8 years, and those who did not had the survival of approximately 4 years. In addition, they had a more than reasonable safety profile with less than 3% adverse events that are severe, not including the post-embolization syndrome. And these adverse events included liver abscesses, biliomas, carcinoid crisis, and cholecystitis. And these are often temporary and manageable, and no direct or permanent liver toxicity was seen. So what does that mean? Well, because it can be given multiple times safely and with good outcomes, perhaps we can consider it more in line with repetitive chemotherapy treatments given at regular intervals rather than salvage therapy when symptom or disease controls are out of hand after you have failed multiple other lines of therapy. Moreover, this study looked at what is associated with overall survival and found no correlation between extrahepatic disease, which makes up to 60% of the study group, and survival. Given time to tumor progression is 26 months, perhaps TACE can be used to delay systemic treatments even in those with extrahepatic disease. And in terms of comparisons, Dr. Tai recently did a meta-analysis of 504 patients showing no difference between chemoembolization and blend embolization in terms of overall survival, progression-free survival, and symptom control. It did show slightly different adverse event rates, although it was not statistically significant, and this is not surprising. In terms of adverse events, blend embolization does come with more pain than chemoembolization. REDNET is really the trial that we're all waiting for. It is now finally closed, and it is a prospective trial looking at TACE versus blend embolization. So hopefully we will get some results soon. In terms of how they compare to systemic therapy, we don't really have any good comparative data except for a paper published in 2020. However, it is based on data that is now over 10 years old. And it showed that liver-directed therapy, including TACE and TAE in the California Cancer Registry, had better overall and disease-specific survival by over 20 months compared to systemic therapy alone. And I want to show you 2 case examples to show you a little bit of what we do. So the first patient is a 54-year-old with small bowel neuroendocrine tumor to the liver. And she had liver debulking surgery and resection of her primary liver tumor 3 years ago. And her liver metastases have been growing and now encompasses 60 to 70% of the liver. And we do not want the disease to grow any further because as they grow, the patient can potentially die from liver failure. And symptomatically, she had loose stools, 4 to 5 days, and some flushing. This is her CAT scan before we did the procedure for her. This is her liver. And what you see is all these bright spots inside, those are our tumors. And I highlighted some of the big ones here so you can all see. And I treated her whole liver over 3 separate sessions with blend embolizations spaced 1 month apart. And during the procedure, you can see how these tumors took up the contrast. And after embolization, you get rid of the blood flow to these tumors with the particles. We follow her afterwards, and to remind you, this is what it looks like before, and this was afterwards. And as you can see, there are far fewer bright spots in the liver, and they're so small, in fact, I can hardly see them. And you can also see where I did treat, the large tumors undergo internal necrosis, and which shows up dark because it doesn't take up any contrast. And the patient did really well and had no symptoms afterwards. And the second I want to show you is a patient with severe hypoglycemia due to metastatic insulinoma, and her disease could not be debulked intraoperatively, and she required significant glucose infusion demands up to 100 mL per hour of D25 infusion, and D25 stands for 25% dextrose infusion. On imaging, she had bulky diseases in both lobes of her liver. I treated her while she was in the hospital, and I decided to treat her right liver first because that was the site with the largest burden of disease. And she had excellent response. So before treatment, she was barely maintained at a glucose level of 60 to 100 with D25 infusion of 100 mLs per hour. And on the day of treatment, and the day after, she had immediate response in her glucose level. However, tumor death follows the treatments a few days later, and we continue to see the drop in glucose level with persistent need of infusion. And we expected these dips because as the tumor dies, it releases a lot of hormones, and that can be some of the most dangerous period of time for the patient. But once she passed this critical period, the patient was able to be slowly titrated off the glucose infusion, and ultimately she was able to be discharged without any infusion, purely on a steroid taper and on the diazoxide, okay? And then lastly, I want to comment on the role of TACE in the era of PRT. So the NETChatter trial came out in 2021, ultimately was a little bit disappointing because it did not show any overall survival benefit in those who had Lutathera compared to double-dose octreotide alone. Further post-hoc analysis showed that the presence of liver metastases larger than 3 centimeters was associated with worsening progression-free survival. And that tumor size shrinkage depended significantly on the baseline tumor size. And those who had tumors larger than 2 centimeters did not change significantly in size. And this leads us to perhaps thinking that embolization can be used to shrink tumors before PRT. Dr. Heckard also showed that liver-directed therapy is not associated with PRT discontinuation, and therefore, as long as liver-directed therapy is carefully given, it does not cause any permanent abnormal liver functions and does not preclude PRT in the future. So to quickly summarize what we covered so far about TACE and blend embolization, it is used for patients with symptomatic, progressive, or bulky liver disease. And we think that TACE and blend embolization are right now essentially exchangeable, and we will wait for the REDNET trial to see if there's a difference. We know that these therapies can be repeated with sustained response, and given that it can prolong survival regardless of whether extrahepatic disease is present, it can potentially delay systemic treatment and help debulk disease before PRT. Now I want to talk a little bit about Y90 radioembolization. So radioembolization is also commonly known as TARE, Y90, and selective internal beam radiation. It is a technique that uses radioactive beads to deliver radiation specific to the tumors themselves. And the radiation used is yttrium-90, which is a beta emitter with an average penetration depth of 2.4 millimeter and a half-life of less than 3 days. The dose of delivery is done transarterially. And multiple studies have shown that the dose is confined to the liver with a minimal biologic elimination of Y90. Important to differ from TACE is that we don't intend to include the treatment vessels. And the tumor death instead occurs not from ischemia, but from the radioactivity. As of the latest guidelines, we know that relative to other type of metastatic liver disease, patients with neuroendocrine tumors live longer. So we know there's increasing evidence that radioembolization can cause long-term toxicity to the liver when the entire liver is treated, especially in a single session. As such, we moved away from whole liver treatment in a single session and focused more on lobar treatment, occasionally even in smaller segmental territories. It is also indicated in patients with prior Whipple or biliary tract instrumentation because it is associated with a much lower risk of liver abscess formation and biliary complications than TACE or TAE. It is also better tolerated in terms of side effects and pain than TACE and TAE, so it is considered in patients who are perhaps too sick to undergo blend or chemoembolization. So quickly about how it is done similarly to chemoembolization in that we go into the arteries of the liver. However, it is a little bit more complex in that it needs 2 different procedures and a few more steps. The first procedure's goal is to map out all the vessels supplying the tumors. And everyone's vessel anatomy in the liver is very different, so it takes careful investigation. And there are multiple, if there are any branches going to the stomach or the bowel, we are going to embolize them with coils to protect the radioactive particles from going to these tissues. And then we deliver technetium-bound albumin, which we use to mimic Y90 into the vessels. And this helps us determine whether Y90 can be safely given. So while technetium is not 100% reflective of the actual Y90 distribution, it is a good enough on spec to detect high Longterm fraction, such as in this case on the right. What a high Longterm fraction means is that a significant amount of radioactive particles will traverse through the liver into the lung. And in those scenarios, Y90 cannot be safely given because it can cause radiation pulmonary pneumonitis. However, if the Longterm fraction is reasonable, we will then order a custom dose of radiation for the patient, and then the treatment dose is given typically on a different day. If a second session is needed to treat a second lobe, then that is typically performed 4 to 6 weeks later to allow some recovery. In terms of short-term efficacy, Dr. Pratt published a recent multi-center retrospective trial involving mostly US academic centers and one in Germany and one in Netherlands. And they showed a disease control rate of 91% and a 3 months objective response rate of 26%. In addition, they showed that symptom control or resolution was achieved in close to 80% of the patients. Now, arguably 3 months might be a little early to fully assess the objective response rate after Y90, which often takes up to 6 to 12 months to fully manifest. And more recently, a multi-center retrospective trial looking at mostly in German centers found a similar disease control rate of 83% at 3 months and a 12% disease control rate at 51%. And in terms of long-term survival, Y90 is associated with increased overall survival of 31 to 41 months, as well as increased global and hepatic progression-free survival. Tumor load and higher grades are associated with worsened outcomes, but it is currently not clear whether extrahepatic mets affects overall survival rate, as one of the multi-center study found no relationship and another did. Moreover, as I talked about before, tumor vascularity on imaging doesn't correlate with angiographic findings, and this 2022 retrospective study also showed that it does not correlate with survival. In terms of short-term toxicity, it carries approximately 33% grade 3 toxicity, and that includes 7 to 8% liver abscess formation. And that is almost exclusively seen in patients with biliary colonizations with prior biliary interventions. But that's still much less than if TACE or blend embolization were performed. Because if that were performed, you will have up to 20% of liver abscess formation rate. And about 7% will have persistent abnormal liver functions. In general, patients tend to have less constitutional symptoms such as post-embolization syndrome, and they feel much better in the immediate setting compared to TACE because they have less pain. But with TARE, we do worry more about the long-term liver decompensation, and multiple studies published in the past really showed of a 1 to 7% TARE-related clinically significant liver decompensation. And that is almost entirely related to a whole liver treatment. And I summarize all the study in this table, including the most recent residence registry that include 170 patients in 36 centers. There are many studies that compared radioembolization to TACE or TAE. There is a retrospective review in 2019 from 2 centers with 248 patients, where about 80% underwent TACE and 20% underwent TARE. They found that disease control rate was greater with TACE than TARE, but there's no difference in overall survival and progression-free survival. But this study is a little limited because arguably patients who received TARE had more advanced disease. And what about toxicity? They didn't find any difference, and we now know there is radiation-induced chronic hepatotoxicity that we talked about, especially if patient had more than 50% of the liver treated, or if they have pre-existing cirrhosis. And this is compared to a 3% hepatotoxicity we have with blend embolization. There is also significant debate regarding the combination of Y90 and PRT, since both are radiation treatments. However, the NETChatter trial showed there's no significant hepatotoxicity with PRT alone. And in looking at combination treatment of PRT and Y90 and other liver-directed therapies, all the toxicity rates are about 7 to 8%. So the long-term toxicity of combination treatment is really not any different compared to TARA alone. And so there's no evidence for or against the safety and sequencing of TARA and TARA and PRT. And we do not know about the safety of combination therapy as we are moving away from beta PRT to alpha PRT. And alpha PRT has some amazing cytotoxicities, but it has a much shorter tissue range of 100 microns. So I suspect that it will be safe to use Y90 with alpha PRT, given how little collateral damage there will be with the alpha emitters. So to summarize, interventional radiologists, interventional oncologists, we offer many cancer-related treatments. Ablation, chemoembolization, blend embolization, and radioembolization, and some of the major treatments that are available for patients with metastatic neuroendocrine tumors, and they can potentially be used in conjunction with other therapeutics, including PRT. Thank you for having me here. That's it. I'll be happy to take any questions.
All right. Thank you so much. That was an excellent presentation. I definitely learned a lot. I live in the laboratory as a PhD, so I didn't know much about interventional radiology, but I definitely know more now. So before I get to my questions, does anyone else have any questions? Yes, Lisa.
Hi, thank you for that amazing presentation. You explained things very well. So this comes up in the patient community quite a bit. You know, there's many people who've had Whipples, and I know you talked about biliary colonization and the risk of abscesses. Can you kind of explain a little bit more? Is this black and white that people with Whipples cannot get certain liver-directed therapies, or how do you weigh this?
Yes. So when you have a Whipple, you get rid of the sphincter that prevents bacteria in your small bowel to enter the biliary system in your liver. And so when you have a Whipple, you become at much higher risk of getting liver abscesses and major infections. Treatments such as ablation, blend embolization, and chemoembolization, they're known to have a significant risk in these populations to cause these type of major liver abscess formation issues, up to 20%. Sometimes we can, if we have to, we can give a very prolonged antibiotics, like a month-long antibiotics, to help minimize that, but that high rate comes despite that, okay? And radioembolization, because it does not completely occlude the blood vessels, does not cause necrosis in the immediate quick setting, it is at a lower risk of creating liver abscesses. And the reason liver abscesses form is because as you have all these dead cells, it becomes like a perfect petri dish for bacteria to grow. It's like all the nutrients for them. I hope that answers your question.
Yes, that's an excellent question. Can I ask a follow-up question about radioembolization? And how do you weigh that right now in the age of PRT?
Oh, that is a complicated question. In our tumor board, we discuss radioembolization and PRT. Even though it's been, shown that it's pretty safe, I try to reserve radioembolization in patients who are not candidates for PRT. And patients who are candidates for PRT are those who are, positive on dotatate scan. And unfortunately, there are quite a number of patients who are not. And in those patients, I definitely consider radioembolization if blend or chemoembolizations are not options, or if surgeries are not good options.
I have
Does
a
that
quick question.
Thank you.
Mm-hmm.
I was wondering, why are these liver-directed therapies not recommended for patients with poorly differentiated, like neuroendocrine carcinomas? Is there anything known in that realm for those patients?
Yeah, I think there was like a trial that I showed earlier for high-grade tumors, they just don't respond well. Yeah.
And then I had another question. How accessible are interventional radiologists and this type of therapy for patients? I'm very ignorant when it comes to this field, but do patients have to travel to a major hospital, or does every hospital have an interventional radiologist? I live in the state of Alabama where we have one major hospital for the whole state. And is it something that patients need to drive far to get this type of therapy?
Yeah, that is a great question. Interventional radiologists, we do such a variety of different procedures. Cancer aside, we do a lot of vascular therapy, a lot of, just abscess drains in general. If patients have kidney infections, they come to us to kind of help manage them. So most hospitals nowadays have an interventional radiologist. In terms of interventional oncology, it is definitely found in all the major academic centers, but is also, mostly available in most of the private groups out there as well. I would say you should be able to find an interventional radiologist and interventional oncologist in your local area. The challenge with neuroendocrine tumor is that it can be very challenging to manage, especially intraoperatively. So if your interventional radiologist feels this is out of their comfort zone, they may refer you to a major academic center to get that taken care of.
Yes, that makes sense. Thank you. And Lisa has another question in the chat, and she asks, how often can patients get embolizations? Is there a maximum lifetime limit? Also, is there a difference in the size of beads you use, and how do you decide this? It's a great question. Okay,
so is there a maximum lifetime limit? So the studies have shown that, you can get 3 cycles. The three cycles are so like whole liver treatments, and it depends a little bit, right? So if I see a patient that responded really well after the first cycle treatment and I don't see any tumor growth significantly for a year or two, I'll offer the second cycle or even the third cycle later on. However, if I offer the first cycle and just the tumor exploded despite that, then I will have to weigh the risk and benefit and determine whether that is the right thing to do for the patient. In terms of the size of the beads or the type of these beads, there are many different brands out there. It is a little bit of dependent on kind of the local availabilities, what size of beads they have. I say anywhere from 100 to 500 microns are perfectly fine. I tend to start small and then I increase in size. And she also asked the risk of carcinoid crisis with liver-directed therapy. Oh, many questions. The risk of carcinoid crisis, one of the things we do is, we give octreotide infusion before the therapy. There is no really a standard protocol in terms of what rate to give beforehand, and I have looked into that. But in patients who are at risk for carcinoid, I do get anesthesia involved, and I have the patient admitted to be observed afterwards. So we work in close conjunction with the surgical team and the endocrine team to make sure the patient can be safely treated. Histotripsy. That is a great question. So for those who don't know, histotripsy is one of the newest ablation therapy out there, and it is not FDA approved yet, but it is a well, it's relatively non-invasive in that no incision has to be made over the skin, and it uses kind of ultrasound frequencies to help kill the tumors and cause apoptosis. Histotripsy is what I will consider as histotripsy is I will treat it the same way as other ablation techniques, in that it will be limited to patients with a limited number of tumors, because you're going to have to target one at a time.
Wonderful. John, you have a question?
Yeah, thanks. That was a really helpful presentation. Thank you. I think, so I was wondering if you could just go over, like, summarize as you know, a patient approaches you, or when you're on the we're talking with your colleagues, among these sort of three options that you presented, how do you decide, other than a Whipple, how do you decide what approach you might take? It sounds like and you think you made this clear before, is obviously for some of them, you have to limit the number of targets, right? But other than that, I guess, so starting from there, could you just summarize that, please?
Oh, yeah. So there's so many different factors we consider. We always consider a patient as a whole. So we take account of prior treatments they have. So what type of treatment they have and how they responded, and what kind of the projection was. Like, did it respond initially and suddenly stop working, or it is still kind of responding, okay? In addition to that, we consider whether it's DOTA positive or not, because we think, yeah, is PRT a potential option in the future? And a major thing we consider is what is patient's functional status, as in how healthy is this patient otherwise? What type of treatment will they be able to tolerate? I work with a fantastic surgeon, and he is very good about resecting, many tumors. So usually if the patient is a surgical candidate, they go down that route first. And if they're not a surgical candidate, then they come to me, and I determine based on all these factors, including Whipple history or other surgical history, or even kind of like, what do they want? What are they going to tolerate? And find a custom plan for them.
And then as a follow-up, that makes sense. Actually, I wrote that down. It seems like this is very custom. There's not an obvious path a priori. On that note, are there which got me thinking about differences across centers, and how different. Really, honestly, my intuition is that different centers might end up approaching this very differently. And so I guess which begs the question, is there a guideline that you follow in this area, perhaps a NANETS guideline, for example?
Yeah, we follow the NANETS, and we follow the NCCN guideline, and I would say most institutions do follow the NCCN guidelines. It's these patients with very unique scenarios, and we often have to kind of think outside the box, or in the gray zone of the guidelines, and we figure out like what are the things we can offer the patients. And it will unfortunately depend a little bit on local expertise, what each areas surgeons are comfortable with, which each areas interventionals are comfortable with.
Yeah, that's the way it goes. Thank you.
Yeah.
Wonderful. Lisa had a question if some of these techniques that you mentioned could be used for tumors outside of the liver.
Yes. So these tumors, okay, it depends a lot on location. So for other type of cancers, we use the same techniques: microwave, RFA, cryoablations, histotripsy, irreversible electroporations. In neuroendocrine tumor, because extrahepatic disease is often not what is the life-limiting thing, so we target the intrahepatic disease rather than extrahepatic disease. In addition, studies have shown that the extrahepatic disease, did not really, having the extrahepatic disease or not having the extrahepatic disease did not impact patient survival. So in terms of risk benefits wise, we often don't go after those. There are, of course, exceptions to those. And there are times where extrahepatic diseases can cause significant harm to the patient, and it'll cause stenosis of major vessels and etc. And these can be addressed differently.
Excellent. All right. Does anyone have any other questions before we wrap up? This has been an excellent discussion.
I do have a very quick question, and maybe just more of a clarification. When you were mentioning earlier about doxorubicin, and TACE is usually done with doxorubicin because you mentioned that's kind of like the standard based on the hepatocellular carcinoma data. But something you mentioned about, is that something that is preferred for patients with carcinoid heart disease or not preferred? I mean,
It's not.
It's not preferred because of the cardiotoxic.
Doxorubicin is toxic, so we avoid that.
Okay.
In fact, in terms of carcinoid heart disease, you have to be very careful of doing embolization.
Right.
Oftentimes it's preferred if the patient has already had their valves repaired.
And that was kind of like my follow-up question, because usually for surgery here, if a patient have a carcinoid heart disease, we wanted to take care of that first before surgery. Is that the same with liver ablation embolization, or is that I think you mentioned something earlier that you want to kind of like, you usually do a very close monitoring with the cardiologist, but like we're very cautious about carcinoid heart disease, so I don't know. Yeah,
I think I am very cautious about carcinoid heart disease. There is not really a guideline in how aggressive you can go with it. If the patient had a valve repaired, the risk of that is much lower, but it's still there. And then you have to kind of always weigh the risk and benefit, and to see if there are other options like PRT, which can be much safer.
Yep. Thank you.
All right, so I think we'll wrap up there. I just want to give a big thank you to our speaker, Dr. Koethe, along with all of the attendees for this month's NETChatter event. This was an excellent presentation, and I really enjoyed our discussion afterwards. I think there was a lot of excellent questions asked and answered. So again, thank you all so much for attending, and be on the lookout for next month's event. It will be the last Thursday in August. So enjoy the rest of your day, and thank you again.
Thank you.
Bye.